Hello, everyone. I'm Brandon Hawker with Open Minds Market Intelligence, and I would like to welcome you to today's Circle Elite Executive Roundtable, Value-Based Care for Transitions of Care in Behavioral Health, the Brave Health Case Study, featuring Brave Health CEO and co-founder Anna Lindow. Anna has a lifelong passion for mental health, and she founded Brave Health to expand access to the type of care that have helped her since adolescence. Prior to Brave Health, she was an operations executive at General Assembly, a global organization that helps adults gain new technology skills. Anna has a BA from Columbia, a graduate certificate in addiction recovery from the University of Florida, and an MS in psychology from Walden University. Paul M. Duck brings over 25 years of experience in leadership and management, focusing on managed care, health information, technology organizations, strategy business development, and market expansion, and customer experience optimization to the Open Minds team. Prior to joining Open Minds, Mr. Duck has served in executive leadership positions with Beacon Health Options, NetSmart Technologies, Coastal Orthopedics and Pain Management, Florida Radiology Imaging, and was named one of America's most fastest growing companies by Inc. During his tenure. Mr. Duck recently served as a contributing author to the book, The New Health Age, The Future of Healthcare in America. Before we get started, a few housekeeping reminders. Your audio will be muted during today's briefing. However, we encourage you to submit any questions you may have using the question box on the right side of your screen. We will present them at the end. The slides and recording from today's briefing will also be available on the Open Minds website by tomorrow. Paul, I'll turn it over to you.
Thanks so much, Anna. It is great to be with you. Certainly, I was very excited to know that we're presenting together and looking forward to hearing more about the Brave Health story and the continuing progress that you all have made. Very excited. And so today I just wanted to kind of set the stage and hopefully set Anna up perfectly, because again, she's a phenomenal presenter that has a great story with Brave Health. And realistically, I just want to just talk for a minute about what specialty provider organizations in our market are most concerned about. And obviously digital, which is a big part of what Brave, their story is, and how they use data and how they interact with the health ecosystem really is an important aspect. And that's really kind of one of the things that I think the industry is seeing right now is that we're looking at how do you deal with the whole person? It's no longer behavioral health or mental health in a silo. It's now an environment where you have to be able to collaborate and effectively know what's going on throughout the consumer's entire experience. The other is that really it's around primary care for consumers with complex needs. And obviously in our industry, that's super important. And primary care is obviously seeing its stature being raised significantly in the marketplace. Home-based services playing a big role where a lot more is being done in the home, especially around addictions, where you see hybrid models being used. And I think that's, the kind of the fifth point here on this slide, but also the social support programs. And I think that's where Brave Health and Anna's story is really fascinating in terms of the way they've addressed it, and I think the way they've kind of attacked the problem, if you will. What we know about the post-pandemic market, I think, is really important, and really having that digital-first mindset is crucial. And again, that idea of integration and care coordination, that's really preferred by payers, and I think we've seen that stand out even more in recent months and over the last couple of years. You see virtual therapy playing a huge role in terms of really kind of renormalizing the marketplace. Also, facility-based services, a lot of that now, certainly post-pandemic, have gone to a hybrid model where you have everything that combines the home environment potentially with in-office services or online services. So you have a lot more kind of innovation that has to take place in terms of provider organizations, and you have to come up with new models. And also price sensitivity, which has been around our market forever, but it's even becoming more important as we move very rapidly to risk-based services. And again, I think it's important to note is that the preparation that we've been talking about for years in moving to value-based arrangements is really now we're at the threshold, and in some cases, are in full risk-based arrangements, which are really crucial. I want to just talk really fast and draw a parallel for you before I turn it over to Anna. We're going through transformation, and again, I would argue that between 2020 and 2030, and I have a futurist friend of mine, David Houle, who predicts that we'll see more change in this decade than we've seen in the last 100 years. So if you look at some of the transformation that happened in entertainment, certainly we see, a large trajectory there in terms of the things where innovation's really kind of been front and center. You see the transformation of the banking industry, and we see more banks now being fully online, being much more in-person, less transactional on a local level. The transition of and transformation of retail, certainly, the physical store moving to catalog, which we saw with this old Sears catalog, and now obviously with the advent of Amazon and all the online shopping options are really, really kind of, again, transformational kind of change. And I think that's where the challenge is for our market. Where is it that organizations are going to rally around to provide that kind of transformational change that's necessary? The digital transformation of news, obviously moving from newspapers to television and now all the online news, and our expectation that we are up to date moment by moment, as opposed to it now being what happened yesterday, and I'll read it in the newspaper. A lot of that now has moved much more rapidly, we see. And obviously the transformation of healthcare, I still think and argue that there's a tremendous amount that we will see in the coming 7 to 10 years, which will really kind of be the hallmark of the kind of innovation that has to happen. And again, I liken and love Anna's story in terms of what she's doing with Brave Health, in terms of the kind of things that they've been able to innovate around, which I think are really super important, and not just maintaining the status quo. We all know Steve Jobs, is kind of when you talk about innovation, he tends to be kind of top of mind, and his big statement was successful organizations will innovate. And I think certainly if you had an organization that was kind of hardwired like Apple to innovate, certainly that has to be part and will become part of your success going forward. If you look at something simple, this was Apple's original logo, believe it or not, with Sir Isaac Newton reading under the apple tree, if you will. But if you look at it today in the transformational change that's gone on over the years to what their logo looks like today, even branding matters, because more and more obviously is moving towards visuals. If you look at some companies that have created massive innovation, look at Play-Doh by example. In the 1950s, it was a remover of coal. And they basically said, we see teachers using this in Ohio, and basically they moved and realized that if they put some color in it, it was a moldable object. And obviously we know the history of Play-Doh. And you see these other companies. American Express started back in the 1800s as a priority delivery service, if you will, for high value items like stock certificates and whatnot. Amazon, we all know that story. Netflix obviously moved and transformed an industry. Uber, we know, transformed local transportation. And obviously we believe Open Minds also has innovated a lot. Started as a paper newsletter, and if you look today at all of the different things that the company does, from the conferences and institutes to the executive briefings that come out every day, to all of the things that we do around consulting services, just enormous amount of full-blown marketing agency, all within that bound. So again, transformational change across these products and companies. Here are all the companies that we probably have known and heard about over the years. A lot of these were not as innovative and literally got left behind. My favorite to talk about is Blockbuster, which most of us probably recognize. That started out renting video cassettes and DVDs, and obviously got surpassed as the streaming services and the mail to your home, which is really where Netflix started, to streaming today. But again, it's important to note, you don't want to be an organization that's like Blockbuster. Please consider innovation. And again, hopefully Anna will motivate and stimulate your thoughts about how it is that your organization needs to think about some of the things that you need to do organizationally that really will, again, cause those kind of transformational changes that I think are necessary. So Anna, as always, really excited to hear about some of the progress that you've been making with Brave Health.
Thanks for having us. We're so happy to be here. Great to see you all.
Absolutely, absolutely. Let me see if I can hand this off to you, or if you can take it from me.
All right, let's go ahead and screen share. Oops.
There we go.
It's the wrong thing. Can you all see Brave Health and Open Minds. I'm going to go into full screen mode. Just want to make sure it's working.
Yes.
Great. Okay, Brave Health and Open Minds. Great. Y'all can see my screen still?
Yes. Yes.
Fantastic. Okay, so thank you so much for that great intro, Paul. I want to talk a little bit today about some of the ways that we can use technology to enable care, not to replace care, right, but to enhance what we're doing on the clinical side, not just so much through care delivery, but a lot as well through the work that we do for engaging individuals in between or around care delivery moments and encounters, and in using technology in order to better coordinate and integrate the care that we're giving with all the stakeholders that are involved. So that's what we're going to cover today. So first, from the perspective of care, transitions of care specifically, I'm going to dive in on this as just a lens into a use case around technology and data for delivery and integration and engagement, because we think it's so important and it's so pivotal for individuals' journeys. Transitions of care are high-risk moments, right? Handoffs can lead to loss of engagement, people sort of not getting what they need in the system and then not engaging with it in the way that we might want. And it's an opportunity for us to use technology to coordinate, which I'll talk about. And there's some really interesting things happening on the reimbursement model side as well. So what we'll cover today is how can we use technology and process to make transitions of care more successful? Where do technology and data play a role most effectively? And what does this mean for reimbursement models? So that's where we'll go today. But first, we'll start with a little context. So what is Brave Health? So at Brave, we're a national integrated virtual behavioral health provider and engagement platform. So what does that mean? Well, we operate in 11 states right now. We treat behavioral health conditions. We have therapy and psychiatry, episodic case management, care coordination, peer support. Everything's virtual. So we don't have any in-person care, but the care is actually primarily delivered via synchronous video in terms of our clinical services, right? So it's not about removing synchronous time between provider and patient. Where we use technology in a really, what we think outcomes changing way is not just that technology that allows us to reach more people through telehealth, although that's good. It's really around the engagement work that we do that lets us then serve members who may need support navigating their care. And we'll talk a little bit more about what that is in a moment. And there's 3 components to what we do. So the first is, the most straightforward one is that we offer treatment, right? So it's a virtual clinic. We're offering outpatient psychiatry, therapy, et cetera. We do integration work. So when we're offering care, we're not doing that in a silo. We're working with primary care providers, doulas, health plans, hospitals, and we'll talk a little bit about specifically that hospital engagement channel today, because it has a particularly interesting use case around how we can use technology to move things forward. Same thing, and we'll touch a little bit on the health plan side as well. And then last but not least, we also do engagement work. So when we zoom out for a second, we think about, well, what if we could wave a magic wand and change one thing about community mental health, which is where we really place our focus? Would it be that we would add more access? Yes, we would want to add more access, but just adding access in and of itself doesn't actually solve the full underlying problem, because if we had unlimited access, but we didn't change anything about, prospective patient behavior, those individuals still don't get to care. What we have just determined through, years of data collection and analysis is that we actually do need to do a good deal of proactive work engaging individuals, both people who haven't become our patients yet but are interested in services, and people who are already our patients and we need to continue to engage them in services. And that's somewhere we placed investment on the technology side to say, well, what would happen if we actually really, really placed energy around this? Could we get different results? And the answer is yes, and we'll talk a little bit more about that in a moment. So because we do use technology not just to deliver the care, but also to engage the members that are referred to us, or the individuals that are referred to us, that leads to a situation where we can get faster connection to care for broad populations. And in practice, one of the things this is really effective for is individuals who meet 1, 2, or 3 of the criteria below, because in these situations, what you see in this Venn diagram here, what it often means is people who fall into 1 or more of these categories can benefit from additional support getting engaged in services, right? So what I mean by that is, let's say somebody, is physically doing really well on their health. They have great support networks. They are able to use technology without assistance. They have no transportation barriers. They don't really have any SDOH barriers, but they want to see a therapist because, they want to maybe improve, maybe they're working on something in their relationship and they want to talk to a therapist about it. For that person, self-service offerings might be just fine. They might be able to be directed to a link of a platform, and nobody ever talks to them or reaches out to them, and they just self-navigate the process and it works great. For the patients that we're talking about, and this is where transitions of care come into play, because often these are individuals who they may have been hospitalized for a psychiatric condition, and might be part of it, especially down here. If 1 or 2 or 3 of these elements are present, then we're in a situation where if we give this individual just a link and say, hey, figure it out, we may not get the results that we want because they just may need that extra layer of support. And that can be true for people with serious mental illness. That can be true for people who maybe they have something really serious in their physical health going on, or just chronic and complex that requires management. Or it could be, for somebody who has SDOH barriers in their life and can benefit from additional support getting connected to care. For instance, a lot of the individuals we work with, they have a smartphone, but they may have relatively low tech literacy. And in that situation, if nobody supports them in getting connected to telehealth, they're not going to get connected. So that's another place that we find that having both a tech-enabled and people-enabled navigation sort of capability set changes the outcomes. And so what we come to then when we look at the kinds of areas we can have a lot of impact is certain populations. And these, sort of flow naturally from this slide. Can be people who have co-occurring medical conditions. Maybe they're managing a chronic illness. Could be in the maternal and postpartum mental health segment. Maybe it's someone who's pregnant or recently had a baby and needs support. Obviously, that's a really monumental medical event, physical health event, and so giving the extra support there to get engaged with mental health services can be really helpful. And then just other populations where there is often more of a lack of access or help for navigation is needed, and same thing with SMI. And along, sort of related to SMI is our high utilizers of psychiatric hospitals. These are folks who we know that every time they are hospitalized for a psychiatric illness, they are given a discharge summary, and in that discharge summary, they have a follow-up plan. The problem is when we look at not just the national averages, but also, looking in sort of more granularly at various regions, we can see that there are a lot of places where that discharge plan is just really not being followed consistently. There are hospitals we've worked with, psychiatric hospitals, where their completion of 7-day follow-up after hospitalization that can be 15%, which means 85 out of 100 people don't have that 7-day follow-up appointment. Well, why is that? Is that because they weren't given a follow-up plan? No, they were given a follow-up plan. So we know that it's not just the access piece. We know it's also the engagement piece. So how do we do that work at scale? Well, first, we think about the idea that the referral process has to be fast. It has to have exchange of data be part of it. And we have to be thinking about how we get all the people who need information in a timely manner. So let's talk about the process then. So when Brave is working with an organization, and let's take the example of a hospital, that organization refers to us, and that could be a fax. So we get discharge summaries from hospitals saying, hey, we're referring you this individual, and it's not even an organization that uses electronic medical records. It could be a piece of paper with handwriting on it that gets faxed to our digital fax processing center. We process that referral, get it uploaded into our system through our technology platforms. We then get right back to that hospital and say, hey, we have a date and time appointment held for this member at this individual at this time. And then once the individual is discharged, we can start our outreach. And what's really cool about this is we have that data point, that key data point about the planned discharge date. So we know when to start that outreach. We know to wait until the time that the individual is likely to have been discharged from the hospital, because otherwise we're not going to be able to reach them, because typically these are facilities where they won't have a device with them. And then we can start getting in touch with that person, again, proactively, right? Start to reach out to them and say, hey, you're scheduled for this time. Are you ready? What can we do to help you? And we find that that's really important, because We've solved a data need here for this referring individual, the discharge planner at the hospital by getting them that date and time appointment quickly. We've solved a data need for our providers because they have that discharge summary directly uploaded so that they can see it. And then we're solving an engagement challenge for the individual by saying, you don't have to remember everything about your follow-up appointments. We're actually going to proactively reach out to you. But of course, you can imagine none of this would be possible without a platform where we manage it. So that's where we've spent time and energy and focus developing a platform that will allow us to manage all of this in a way that we can do it at scale, thousands of times a month. Otherwise, it would be, how would you ever manage that level of communication without tracking and automation? So what we found there is that the tracking piece and the ability to get information to stakeholders is key. And then also the automation piece to say, oh, here's a reminder, this person's discharging tomorrow. Okay, they're kind of come up on our list for outreach today, that kind of thing. And so we've kind of created a few pillars or philosophies that we use in this work. So, and you've heard me talk about some of this already. So I'll actually start over here with this proactive and reactive piece. The first thing is, like I was talking about, with the individual who, needs extra support to engage in care. Well, if we only have the individual reach out to us and we respond when they do, we may lose opportunities, just like the one we were talking about the transition of care moment, where the individual is open to care. We are actually catching them in a window where they are willing, right? From a stages of change perspective, they're ready for the conversation, but they may not take action themselves. We want to make sure that we can take action as well. Again, only going to be possible if you have technology that helps you track and outreach. The second piece, going back over here, loops, not lines. And what do I mean when I say that? So let's take an example of, going back to the example we're talking about in transitions of care, but layering in the use case of a health plan. So, let's use the use case of a primary care physician. So if a primary care physician refers us a patient, we do the same process where we're getting, we're outreaching to that patient and engaging that patient, but then we're also getting records back to that PCP, right? We want records from, of course, with consent of the individual. We want records from the PCP, right? We want to know what's happening in their care. And then we want to get that information back to them. That's a loop, right? Versus the line or baton handoff where we say, okay, you've given us, when you refer us a patient, we get a one-time maybe fax of some of their records from their PCP, and then we don't ever talk again. Well, that's problematic because we're missing an opportunity to keep in coordination and keep delivering care that makes sense to the patient and is integrated for them, versus just saying, okay, well, there was a handoff. And again, this is one of those things where, okay, we have to figure out what platform is going to be best for us. It could start as simple as simply having a secure file sharing environment or something like that, right? Where, with consent of the patient, you can do that sharing. And it can get as sophisticated as bilateral, bidirectional EHR integrations, right? There are lots of possibilities. But the key that I want to keep focusing on here is, it's not likely, or in my experience, it is not likely that the way that an electronic health record system is structured will really have this mindset instilled into it. The electronic health record system is really about how you care for your existing patients, and it doesn't really have a lot of thought necessarily about how you integrate with other organizations or how you work with people who aren't yet your patients but want to become your patients. And so one of the first questions we have to ask ourselves is, what technology and data platforms will help us support the concept of loops and not lines? At Brave, we've decided to have, a separate technology platform that does that work. I think there are multiple ways to do it, but I do think that the first thing to say is, okay, what communication do we actually want to be able to have with prospective patients, current patients, and other providers, and what technology is going to support us in doing that? And so, what does this mean in practice? Well, we're doing a lot of, proactive work engaging patients and prospective patients, as we talked about. This means we can actually get about 2/3 of people who are referred to us to opt into services, which is great, because if you think about what that could mean, for a business, well, if we don't do any work to engage people who've outreached us, I would hazard a guess that probably would be somewhere between 10 and 15%. That would be my guess. Like if you did nothing. And if you do lots and lots of work, it can be in the 60s, right? So the question, I think, for any organization is, how important is it to us that if someone indicates interest in getting care from our organization, that we work very, very hard to get them started in care, versus another way of thinking about it might be, there are people who indicate interest, but it really, in a world of constrained resources, you may not say now is really the right time for us to focus on changing that paradigm. But still, I think it's a good question to ask, and always know, like, what are we shooting for? It's never going to be that 100% of people who indicate interest participate in care, but is that something that makes sense to measure? For us, we feel like it makes sense to measure because we want to know about the universe of options of people who could participate in a service or might be interested in participating in a service, because we cannot treat who we cannot reach. So once we get into a place where we have the muscle built around reaching and engaging people who are interested in participating in care, then we can treat them. Once we can treat them, we can change outcomes. Once we can change outcomes, we can deepen our relationship with health plans. Once we can deepen our relationship with health plans, we can access more patients, right? So it's sort of like this virtuous cycle that you create. So when we think about what that means in practice, it actually really does impact health outcomes, because when we look at a population of people, if we do nothing to intervene around engagement, we're going to get different results than if we do. So at Brave, we've been able to drive as high as a 90% reduction in readmissions. And this is for a very high admitting population, a population of high utilizers like we were talking about before. This is for psychiatric hospitalizations, and it correlated to a 2/3 reduction in costs for the plan. On the physical health side, we also see improvements, right? Because it's not just the behavioral health condition that's going to be improved if we treat behavioral health. We can also see an improvement on the medical side. So we typically see somewhere between I'll call it 15 and 40% reduction in medical spend when we do this work, which you can imagine, right? For if you work in a primary care environment that has behavioral health, or if you're working in, an FQHC or something like that, like this can really be a meaningful change in population health if we start to do that work to engage people in their behavioral health services that they need. So let's talk about it on just a little bit more of a detailed case study. So this is a case where we actually did this work to work with specific facilities. We went to the facilities and we said, we're gonna do a loop with you, right? Instead of you just putting the discharge plan in the members, the patient's file and handing it to them in an envelope. We want to do this with you, where you send us the discharge summary, we get it uploaded into our systems, we communicate to our providers, we communicate back to you what's happening with the patient. We let you know when the date and time appointment is, so that you can really solidify with them that that's what's going to happen. Then we reach out to the patient and we follow up with them on the appointment they have scheduled. And if we do all that, what will happen? Well, here's what we saw. We saw almost a doubling in 30-day follow-up after ED visit for a mental illness. And we've seen pretty consistently a similar improvement rates, but pretty consistently in the mid-50s for performance around 30-day FUH completion and that's follow-up after hospitalization for a psychiatric illness. And this is for individuals we've never met before. So what's cool about that is it means that we're taking people who were not connected to a provider before, or being connected to Brave for the first time. And through this approach, we're able to get more than half of them into a service within 30 days. And there's nothing magic about it. The only thing we're doing is reaching out to the individual on the timetable that they've discussed with their discharge planner, after having given the discharge planner information about when we're going to do this and getting data from the hospital. Now, in practice, of course, there's a lot of operations and tactics that have to be considered. And yes, we need to find a place to track everyone. Anyone who wanted to do something like this would need a platform to track it. And that's where the work really was for us. And so to zoom out for a second and talk about how this ties sort of to technology and what we do to get this kind of thing put into play. Well, we start with the pay for quality measures that a health plan really has. That's typically where we start. And we say, what are the quality measures we're solving for? Let's make sure we're focusing on the right things. What can we do at Brave to help? And then where can we go from there to make a plan? And that is what informs us then working backwards from the outcome we're trying to solve for. We then can look at, well, what would we need to track? And once we know what we need to track, we can look at what systems we need to do it. A lot of things can be done within the EHR, but again, you may need additional tools, or we found that we need additional tools to do so. And so key takeaways. First, Tight data-driven coordination loops and proactive outreach are two keys to transitions of care success. And it's not just transitions of care, right? It's also engagement of existing patients. And a lot of it can be automated, right? There are platforms now that do automation where you can say, I want to just send a text to my existing patients once a month checking in, right? Could be something as simple as that. I have been really inspired and encouraged by some of the things that the team has come up with at Brave, and then partners that we work with as well. When I think about the idea that we can really apply things that we see in other industries, right? So if anyone who's listening has a pet, you may have been in a situation where the veterinarian calls you, sends you a postcard, texts you, like, I have a dog. They really work hard to make sure that my dog gets his services every year. For myself, though, as a human, I don't really get those follow-ups from my provider. So a lot of times the questions that I ask myself are, well, what would we do? What would we choose to do? And what kinds of technologies would we use if we applied the thinking to healthcare engagement that we apply to some other parts of our lives, whether it's taking your dog to the vet or even just other services that you use? Don't they try to make sure you have what you need? Don't they try to make sure that if you were interested before, that you're getting follow-up? And we certainly see that. And there are a lot of sort of models for this, but they're not necessarily commonly applied to healthcare and especially behavioral. Second takeaway for me from this experience working with hospitals and other provider types is that fee-for-service can be a limiting paradigm, especially for transitions of care. And what I mean when I say this is, one of the challenges, and this is, I think, an open challenge that we need to work through as an industry. One of the challenges is I'm describing things that we do at Brave. Lots of other providers probably also do them. They're not typically things you're paid for. A fee-for-service schedule is not going to pay you for outreaching your patient that didn't show up to an appointment. You have a no-show, you call them, hey, what happened? We missed you today. Can we get you rescheduled? That's not an encounter, right? If you have thousands of patients and you do that thousands of times per month, you need a whole staff that just does that work. That's not paid for fee-for-service, because fee-for-service isn't taking into account the idea that they're not taking into account the idea that you can't treat who you can't reach, and that the provider actually has to do work to reach the member or the patient or the individual. And so with that in mind, it's been, I think, an interesting thought exercise for us to start to talk to plans about this and say, we all want the same thing. We want individuals who need care to get into care. There are actions that work. Those actions can be made stronger and more effective and efficient and scalable through technology and data. Technology and data have a cost, and the actions have a cost. A fee-for-service fee schedule doesn't really do it. What are the other options available to us? And this is where I think an episodic or value-based arrangement is a natural fit. Why? Well, because then we're thinking about a period of time and saying, during this period of time, we want to make sure that this person gets what they need. That might take 100 minutes of outreach. It may take 5 minutes of outreach. Depending on how we use technology, it might be a lot of people on the phone time. It might be almost none. Depending on that individual's tech literacy, they may need help from somebody at Brave to get them, figuring out how to use their smartphone. They may not. But when we think about it more from this concept of it's a period where we're engaging the person and getting them to a specific destination, engagement in behavioral health services, I almost like to use this, the concept of like a knee replacement, right? What are we doing with a knee replacement? We want to make sure that this person's mobile and has, what they need to be able to use their joints fully. That's not going to look the exact same way every time, but the destination looks the same. And when we think about people who are high utilizers of psychiatric hospitals, et cetera, we want the destination for them to be stable outpatient. And that might take different interventions. And if we measure them fee-for-service, we're probably, and pay for them fee-for-service, we're probably not going to do all of the things we could be doing. And so that's why I think, I'll close with this, there's a huge opportunity for us as an industry to improve overall health outcomes and reduce costs. But it will take and does take innovation in not just how we deliver services, but what we do in addition to the clinical services we deliver and how we're paid for them. So I'll stop there.
Anna, great job. I mean, again, I'm sure our audience probably has an enormous number of questions, but let me ask one that I know is probably top of mind for many of our attendees. Who are Brave Health's largest payers?
Sure. So mostly Medicaid. We work across, right now, I think I said, 11 states, and it's about 2/3 Medicaid. And then we do have a good deal of Medicare. And we also, when we're working with hospital discharges, we actually also see a lot of individuals who have individual marketplace insurance. Often those networks are less robust, and they have fewer options. So it can be a really good thing to add, like a scale option. I'll
Sure.
also say the payers that we work with, they're across the states that we're in, but about 20% of our patients are in towns that have 2,500 residents or fewer. So we actually have quite a robust rural health operation.
Great. Obviously, dealing with a huge problem, I think that a lot of communities deal with. So, how have you seen health plans kind of respond to the Brave Health model, which is, again, very innovative?
Thank you so much. Well, I think, our goal, I think they see us for what we are, which is in addition to an existing infrastructure. So Brave, I want to be very clear that, like, Brave really doesn't, can't, and should not replace the amazing organizations that are on the ground doing work in the community. We are not feet on the street, right? We're virtual, right? So we're not going to go into a member's home and do a home visit. We're not going to, be able to do a blood draw or, do some of the community health work that organizations do, or mobile crisis, right? There are lots of things we have virtual versions of, but there are things that have to happen in a community, and they're always going to be that way. The way we think of ourselves, and I think the way health plans see us too, is even if we 10x the capacity that is in communities today, it wouldn't be enough, just because the demand in our society is the way that it is. And so what we think of ourselves as doing is adding a layer of support that should hopefully enhance what's available to people, not replace. And I think health plans get that, and they often encourage us, they often introduce us, for instance, to primary care providers and say, hey, can you work with this PCP? And we have FQHCs from the Rio Grande Valley in Texas to the Finger Lakes in New York that we work with. And in some ways, the populations are really different, but in other ways, it's kind of the same across the board, which is everybody wants the same thing. We want to help people get fast access and get them engaged in care when they need it, in the way that they need it. And sometimes Brave is the right option because we're adding some layers that may not be available in the PCP office, for instance. So I think the health plan does see us as one paintbrush within, I don't know, maybe that's not a good analogy. I don't know how many what you store paintbrushes in, but we are one tool within a toolbox, I guess. Like, we're the screwdriver and something else is the wrench.
There you go. So as I think about, you made a great point about fee for service, and certainly your model, we know the ineffectiveness of fee for service, I think. So what models, if you look across the landscape of the states that the Brave Health is in, are you, kind of what percentage or what arrangements do you have in place that both that aren't work better than others, with like fee for service, risk-based contracts, case rates, and whatnot?
Mm-hmm. Yeah, so we do lots of fee for service, and I think there's a place for it for sure. I'm not advocating for taking away fee for service. I think, again, it's like a portfolio approach. We really do like the case rate model for certain populations. We think it makes a lot of sense if you're thinking about individuals who sort of clearly qualify for something. So one case rate or episodic model we have is based around people who are in transitions of care stages. So if you were hospitalized for a psychiatric illness within the past X days, we do this and this, we do this and we're paid in a bundle model. That makes a lot of sense, but that doesn't mean that person's going to need that forever. Let's say they're stable, 6 months from now, they could continue to be a Brave patient, and we could bill for their encounters fee for service, and maybe that's fine, right? So I think it's good to have a hybrid. I'm certainly very interested in possible applications of risk-based models for behavioral health, although I think we have a little bit more work to do there, just because at this point, the risk is typically, in my experience, attributed to primary care, right? Sure. So then the thinking really becomes, well, how could we Brave augment or support what primary care organizations are doing in order to help them meet their overall total, their total cost of care goals, their quality goals? Because in that sense, it's, risk is almost as if the provider becomes an insurance company, right? And so we see that a lot with primary care. I think it's more nascent for behavioral health, but it will be interesting to see how it develops.
And I think, you also have to, in your enterprise, really understand what quality and measuring progress looks like. What kind of tools does Brave Health use to measure both quality and progress?
Yeah, so we look at a few different things, and for us, quality falls into buckets, right? We have cost as one of the things that health plans look at, right? So that could be like some of the things we were talking about around physical health, looking at claims data, physical health, medical spend, pharmacy spend, behavioral health spend, et cetera. We have things that sort of fall into that HEDIS measures, potentially preventable events buckets, like 7 and 30-day follow-up. There's several that relate to behavioral health that we see states look at a lot. And in Medicaid, these are really highly looked at. In Medicare Advantage and in the individual marketplace plans, we see readmissions be more focused on. These are things where sometimes we can measure them ourselves at Brave, and sometimes it requires the health plan, right? Like if an individual readmits, we may or may not know. So this is, again, where we come back to the idea that I think we have to be realistic. Whenever we start conversations with the health plans, we try to be realistic with them around things like, if you want to know medication adherence, you're going to have to get data to us, because we're not going to, unless you tell us, if we don't have pharmacy claims data unless you give it to us. If you give it to us, we have lots of options. But if you don't give it to us, we're not going to know medication adherence except for what the individual reports. So then that brings me to kind of the third category, which is symptom presentation and sort of clinical outcomes that we can measure internally. And we use standardized screening tools, and that's built into our internal platforms, both on our electronic health record side, but also at a rolled up population level, we use business intelligence tools there. So we happen to use Tableau, but Power BI and Looker kind of serve a similar purpose.
Right.
And there's actually, there are other platforms where if you don't have a business intelligence platform, but you want to be watching standardized screening tool performance, there's a platform called Mira, M-I-R-A-H, that does this. It's really great. And there are other things out there that sort of integrate nicely into EHRs. And if it's not yet a priority for an organization to go to a full business intelligence tool deployment, there are sort of middle points solutions there. And then the last, but certainly not the least important area that we place a lot of focus on is engagement data. And kind of like I was saying before, I said a couple of times you can't treat who you can't reach. Well, you can't reliably reach people unless you're measuring that and saying, this is something we care about. So we actually also focus a lot on what's our contact rate, what's our opt-in rate, are people who are showing interest in care actually coming through to the point that they become patients? How long does it take? Days to first appointment? And then how many encounters people have a month, right? Like, are they engaged and how long do they stay in care? Those engagement metrics, sometimes they sound on the surface like business metrics versus clinical metrics, but I'm a true firm believer that behavioral health services work, right? So I'm operating from the perspective of these are people we want in care. So that means we have to measure all the things that relate to them being in care, not just, okay, 10,000 people came to us and said they were interested in services, and 1,000 of them got a service. And for that 1,000 people, they had a 25% symptom reduction. Well, that's great, but there are 9,000 other people who didn't get services. And I think, it was something that really stood out to me in graduate school. All the research I saw was about the people who had care. I never saw research around, and this could have been, I know there is research, but like the focus skews heavily towards what happens once a person is getting care. Of course, that's critical. But I think when we think about population health, and just societally, what do we want to do as a healthcare system, as providers? Well, of course, we are primarily, we are first and foremost, of course, we have a responsibility to our patients. But I do believe we have a responsibility to try to move forward the health outcomes of people who express interest, even if they do need a little bit more support to get into care.
Right. Yeah, I think, if you look at the levels of acuity and those, percentages that you never see services delivered to them, I mean, those are the high spend, and oftentimes they tend to slip through the cracks in the industry. So to me, it doesn't matter. The delivery vehicle obviously matters to your point that you made earlier, but the fact is that getting them seen is really super critical in terms of.
And that's right. I mean, and the same logic applies to in-person care as virtual here, right? Whether we're saying we need an episodic model or we need a risk-based model. I think risk-based models can work better actually sometimes for in-person providers. because you have a geographical population. But whatever we're saying, however we're saying we're going to get paid, the idea then is, well, we're going to do things that are not reimbursable fee for service in order to generate different outcomes. And in our case, that has a heavily digital and data-driven outreach approach. But there are other organizations that have community health work approach, right? There are other organizations that do a ton of work in hospitals where they're actually going on, on the unit and working with the teams that are there. Yep. There are other groups that have physical presences in PCP offices. All of these things, it's, to me, like, it's not about celebrating telehealth as the best or only delivery method. It's about considering that the patient journey doesn't only start once they're established, right? It's that to get truly differentiated outcomes, like you were saying, Paul, the system, and including but not limited to payers, like we really need payers to recognize that we have to help providers have the incentive and compensation structure to invest in the work that gets people to care, because otherwise it doesn't, right? Like, that's a gap then.
It's huge, especially in the rural environment, which I know, is a high degree of focus for your organization.
Yes.
But the fact is that as an industry, again, having those gaps filled is super critical. And I think the other thing, I guess, just in terms of questions, is that as you think about Brave sitting in a healthcare ecosystem within a community or across a state even, what type of, obviously you have very sophisticated data infrastructure and understanding of what's going on with the individual. How and what mechanisms do you use to share that information out to other constituents in the healthcare ecosystems?
Yeah, so it's an interesting question, and we've thought about it a lot, because on the one hand, we would love to give everyone like a fancy platform they could log into. That's possible. But on the other hand, I know, like, if my providers, right, if at our providers, if I said, hey, I have this thing for you and it's awesome, but you have to create a new login, it's going to be in a new screen, doesn't touch the EHR, it's just a separate thing that you're going to use, and it does everything you want and it's amazing, I would still hear, but I don't want to log into another system.
Right.
And I understand that. I don't want to log into another system, right? We can get that. And so we kind of tried to take that logic and take a similar approach where we know health plan case managers live in their chart. We know hospital discharge planners live sometimes on a clipboard, right? Like that, we get things all the time where it's the discharge summary is written by hand, right? And then we know that PCPs live in their chart. Mm-hmm. And so the first question is, well, where do you live? And then the question after that is, how do you get information out? And then the question after that is, how do we get information back in? Because we're probably not going to change where they live. We have seen results over time, providing people really easy referral mechanisms. And we have on our website, we have a referral form that takes about 60 seconds to fill out. And that has been really successful, but it took probably like 6 months to help educate people and generate behavior change around that. It wasn't overnight. But what we've landed on by asking that question of where do you live is we actually just said to people to fax us. Like, if you use fax, send as many fax away. Like, because it's actually faster for me to change the behavior of our team and to create workflows for us to process faxes, which one of the things that we're doing on the product development side now is actually building like a robot that reads faxes and turns handwriting into typing, which is kind of fun. But like, would I rather change that, or would I rather change the behavior patterns of 2,000 hospital case discharge planners? Like, I can't change that. These are organizations that have had the option to, have elected not to use electronic health records for a lot of reasons, and they've made that decision consciously. So I'm not going to come in and say, no, I think you should use my fancy thing and that should work for you. Like, it's not up to me. Right. So in practice, what that looks like is we ingest hundreds of faxes a week. Like, I think it might be thousands. And we also have oriented our triggered messaging, like when information goes back to a discharge planner or a case manager, around email, because we find that everyone uses email. Even if it's a hospital that doesn't have electronic health records, everyone uses email. It's not necessarily the ideal thing to get information back into charts, and it's not what we do all the time with PCPs, but we have kind of kept this thing, this belief system constant, which is I've seen so many good ideas die on the implementation vine when it's, and now we all start using this new platform. It ends up being, that's what happens when like people let the CEO say what they want to do, right? Versus actually trying to listen to the users. And it's a risk for me. Like I hear myself all the time saying, oh, but wouldn't it be easier if we just did this? And I have to be reminded, like, it might be easier for you, but you're not the one who's running around 24 different hospital rooms with a clipboard.
That's right.
So
Yeah.
it's a principles concept that one positive externality is we're not actually building as much technology that goes to people and has to be used and maintained.
Right. But I think, you know, just in terms of the way you've innovated workflow and strive to actually automate functions like faxes. I mean, to me, thinking about faxes, and I know Monica Oss, our CEO, has talked a lot about the idea that healthcare still is so fax laden.
I always say we're
really
keeping
kind of
together in
remarkable. And the fact that you're implementing technology to do, you know, character recognition and be able to make use of those faxes is really remarkable. But the fact is that it's, though a simple low-hanging fruit example would be faxes, I think, in terms of the way this ecosystem of healthcare could actually interoperate so much more effectively.
Yeah, it is. It is. And that's the thing. It's like tough to keep in. I find that one of my challenges is keeping in my mind both like there really is no reason it has to be this way but it is this way.
Right.
So what's our goal, right? Like it is this way. Well, I think there's probably less faxing than there was 10 years ago, and there will be less faxing today and 10 years from now, but it's not going to happen overnight. On the other hand, we now have, you know, with recent legislation, I think it was maybe the Cures Act, we now have a situation where every health plan has to create an API that external parties can plug into, and with member consent, the external, like the provider or, you know, other entity can then get that information, including like prescription history, member demographic data, care plans or case managers have created, their other providers, like all kinds of stuff. Right. And so that's one of the things we're working on with this cool company. It's called Flexpa, Flexpa. They have created a platform that actually gets all the health plans together and gives you, the provider, like one place that you can access data from all health plans. And anytime one of your patients consents, you can pull that data into your EHR, which I think that's, you know, like that's one of these examples of, on the one hand, I'm like, how are we still using fax machines? And on the other hand, I'm like, wow, this is so cool that I could never have imagined that this would happen. So I try, I don't always succeed, but I try to keep an open mind to the idea that we're just one legislative change away from interoperability improving at any time. We're one, you know, like federal bill away from finally getting funding for something or another, right? So I also try to keep an open mind that things do change and we do see improvement.
For sure. Yeah. No, and I think, you know, as you think about, you know, all of the opportunities, and again, that's the reason why I think change that's ahead of us will be very, very significant. And I believe swift change, unlike the conversion of faxes, but I believe that we have a frontier ahead of us that will cause massive change very rapidly.
Yes, and to from your presentation earlier, Paul, like I certainly can remember ordering DVDs from Netflix, and now it's very hard to imagine that. So
exactly. So any final words to leaders in provider organizations, especially around how do you create this infrastructure, this data mindset, and being able to use it effectively, and even some of the mindset in your leadership with your organization as it relates to getting people to innovate rapidly? Any advice on infrastructure and kind of leading in innovation?
I think it's an ongoing journey for all of us, myself included, right? Like if you're doing things that haven't been done before, then they haven't been done before. So we expect that our team will need to adjust, and it's incredible like how our providers learn things and pick up new tech and have great suggestions, and we learn from them. So I think the biggest, like before starting Brave, I had a background working in the technology field, and so the biggest thing I learned from that world is kind of like what I was saying about the discharge planner with the clipboard, like your users actually know what they want and what they need. And the best thing we can do is look at organizations that are doing stuff that we think is cool, try to learn from that, but also look internally and say, what would help you do your job better? What would be easier for you if we could fix? And then look at the platforms out there that we can, and we've talked about this at Open Minds in the past.
Yeah.
Probably things you can buy, right? Like you don't actually need to build anything to start. Even something like Mira, like I was talking about, it's not prohibitively expensive. They work with CMHCs all over the country. And that could be something where in 30 days, all of a sudden you have standardized screening tools and tracking up and running. And it doesn't require any development. You don't have to have a technology team. You don't have to have an engineer on staff. You don't have to hire a consulting firm. Like the vendor you're working with does it for you. So I would say the two pieces of advice or the insights I've had from my own work, not necessarily advice, are the providers actually know what they want. And it's some work to filter through it and learn what the most important things are. And then once you know what the most important things are, 8 out of 10 times, something does it on the marketplace already. And those last 2 out of 10 times, okay, you may have to build something, but you could probably put that at the bottom of your list.
But for the most part, some of the best ideas are borrowed.
Yeah, there you go. Exactly.
Anna, every single time I get to hear you and we get to talk, I learned something. Today is no exception. You're phenomenal. Continue to do the great work that your organization does and continue to innovate. We're excited to have you back at some future point. And again, best wishes to you and in Brave Health and what you're doing.
Thanks for having me. Great to see you all.
Absolutely. Anna, before you go, and Paul, you as well, we actually did have some questions from our audience.
Oh, sure.
So I'd love, we have a few minutes left, we can get those answered.
You bet. I see one.
What?
I see one about the discharge date.
I'll just read them off to you. Yeah, so how do you know about discharge occurring if the hospital doesn't share the expected discharge date?
We always ask them for it, or we try to ask for it. And sometimes they're like, I really don't know. My best guess is whatever. And we know it changes, but at least it gives us like some ballpark. It's not perfect. And this is why you're going to have a little bit better, like you're always going to have naturally a better performance at the 30-day follow-up mark than 7, because sometimes the person was supposed to be discharged on May 1st, but then it's actually April 30th, and then you lost a day. Like it's not perfect, but we do at least try to get them to give an estimate.
Awesome. In your rural areas, how do you communicate with individuals who don't have a phone or are homeless? A large portion of several organizations' clients are in rural areas and they may not have access to a phone.
So it's a great question and it's hard. I would say what we've seen that's been really the game changer is that the health plans will supply a smartphone. There has to be an address for it to get mailed to, right? So that is a barrier. If you are a community organization and you can work, like I've had health, we don't have a physical presence, right? As you know, so we don't have that option of like mail it to us and then we, but the health plan will get a smartphone to the member. The case manager will typically has that available to them through Lifeline or SafeLink, their programs. What we saw is by 2018, Medicaid beneficiaries had smartphones at the same rate as the American adult average. That wasn't the case even in like 2015, 2016. So, and I think it's because of those government programs. So I always try to start with the health plan and say, can you get them a smartphone? Because if you could get them a smartphone, we can do this.
Okay. Is Brave looking to take total cost of care risk or just risk of behavioral health services?
I think we would, if we did total cost of care risk, we would do it with a partner. Like we would work with a primary care partner. And that is interesting to me. But we're not a primary care provider, and there's stuff we would need to do in order to make that possible.
Okie doke. It's now 2 o'clock, so just in being, considerate of everyone's time, I want to thank you for joining us for today's web forum. I would like to remind everyone that the slides and the recording will both be available tomorrow on the Open Minds website. The Full Circle Elite Executive Roundtable series is also available on demand as part of an extensive Open Minds library, and it's also available on our brand new Open Minds YouTube channel as well. So join us next roundtable Thursday, May 26th at 1 p.m. for our next Circle Elite Executive Roundtable, The Future of Person-Centered Care in California, the Pacific Clinic's case study. It will be featuring Pacific Clinic's Scott Fairhurst, Vice President of Outcomes and Evaluation, Analytics and Training, and Laura Pancake, Senior Vice President, President of Clinical Operations, Los Angeles South Coast Regions. It will also feature Richard Lewis as a moderator. For a full list of upcoming roundtables or to register for the May 26th event, please visit the Executive Web Roundtables under the Events tab at openminds.com. Thank you so much.
Thank you.